A very good day to everyone. Welcome to the grand round of breast cancer, which is hosted by ecancer and it's brought to you all by Global Quality Care Webinar Series. So my name is P.G. Roy. I am moderating today's webinar, and I'm a consultant breast surgeon at University of Oxford and Oxford University Hospitals in United Kingdom. I am very pleased to announce today's speaker, Dr. Nwamaka Lasebikan, who is a clinical and radiation oncologist and director of oncology in Nigeria Teaching Hospital. She's also president of Association of Radiation and Clinical Oncology for Nigeria. She's going to talk about cost-benefit analysis of new cancer medicines, a difficult choice for government. I will pass on the mic to Dr. Lasebikan. Welcome, Nwamaka. Thank you very much.
Hello, everyone. Thank you, PJ, for the kind introductions. So briefly, I'll be talking about the cost-benefit analysis of new medicines and really highlighting on the difficult choices of governments, particularly governments that are located in the low-middle income countries where funds for healthcare are limited, and equally limited really is the funds that go to cancer care. So this is basically the outline I will have chosen to talk about this topic. So just for people on the call who would try to understand a little bit of the background of my country. Nigeria, is located in the West African region. It's a large country with over 900,000 square kilometers landmass, and it houses over 211 million people. And we really do think that figure is really not correct, but we are trying to do another national population census, and we think that this would be a little bit higher than it is currently. But with the population of 211 million, it makes it the 7th most populous country globally, and it's indeed the largest country in Africa, accounting for about 1/5 of the entire African population. The population is diverse and comprises of numerous ethnic groups, with each group having their own language, having their own culture. We have 3 main religious biases in Nigeria, and the religious biases are really very strong and often affect the health-seeking behavior of the populace, and also has a bearing to how much really is being offered and devoted to healthcare as well from the family perspective. It's also said to be one of the largest economies, emerging economies in Africa, and it has lots of diverse mineral resources, and it has a very rich and beautiful cultural heritage. We have quite a number of some of the richest people in the world domiciled in Nigeria, and we also have a lot of poor people in Nigeria, often with more than 40% of the population really living below $1.25 daily. So I'll talk a little bit about how our healthcare system operates. We run what is called a 3-tier health system infrastructure, primary, secondary, and tertiary level. And of the 3 levels, it's actually only the tertiary level that has really, advanced in terms of the progress. And this poses a lot of challenges for us because more than 40–50% of the population actually are rural dwellers, and the primary health system is not strengthened to care for their healthcare needs and offer basic services that they would require. The country also has a dual burden of both the communicable and the non-communicable diseases. Particularly, we struggle with a lot of malaria, and the prevalence of HIV/AIDS in Nigeria is really quite high. And that again poses another challenge for us because we know that cervical cancer is 6 times more common in patients with HIV/AIDS. The workforce, as I'm sure it's the same for many other LMICs, is limited, and is even more so with the brain drain that is currently going on, with lots of people going on to higher income countries to seek economic gain, but not just for economic benefits. The infrastructure, the healthcare infrastructure is also limited here. So it's also a question of having fulfillment or lack of fulfillment, really, with working in some of these facilities with very limited infrastructure. So that has really propelled the massive brain drain that we are currently witnessing here in Nigeria at this time. Most of the healthcare budget allocation to the public sector is from the federal government. So the healthcare system basically runs on public and the private. The public funds the tertiary health centers, the primary ones as well. These are the two ways that people get it. But more commonly now, we are seeing an increase in the number of public-private partnerships at the tertiary level. And we believe that this is helping with infrastructural development. But again, that comes at an increased cost to the patients. We're struggling with universal health coverage. There's a recent motivation by the new government to try to ensure that the national health insurance, that every citizen has coverage by the national health insurance. There are also talks of really putting cancer care on the NHIA. We've seen some small advances in that front, but obviously would like to see more. So currently, almost 95% of the expenditure for cancer care is out of pocket. And of course, as you all can imagine, that comes with a lot of financial stress and strain, and many times often people and community families, and because we have a communal living, so not just the patient but the patient's immediate family members are often pushed into catastrophic spending and financial toxicities. So these are the statistics for cancer care in Nigeria. This is according to Globacom. 124,000 plus cases where new cases were identified. This is from 2020 data. But even as we quote this data, we do so with some reservation, because we know that our cancer registration services are, again, not as strong as it should be. We know that this is a gross underestimation of our current cancer burden and indices that we see here in Nigeria. Even as we see the new cases, we can also see that the number of deaths from cancer is also high. And in fact, it's actually a growing epidemic here in Nigeria. The three commonest cancers we see for females are breast, cervical, and colorectal. And for male is prostate, colorectal, and non-Hodgkin lymphoma. We've begun to see an increase in the number of patients that have colorectal disease, colorectal cancers. And this is also something that we see in the middle-aged, who are supposed to be at the prime of their lives, able to commit to the GDP growth of the nation. So it's also a worrisome development for us. Late presentation is the hallmark of presentation. Patients often present in advanced metastatic stage, and sometimes when little or no effort can be done. They've spent quite a lot of their funding going around looking for alternative means. Like I mentioned at the beginning, health literacy is something we are struggling with. Health, of course, that also talks about the health-seeking behavior in our patient population as well. But for those that do present, access to treatment is also low. For a number of reasons, patients have to pay out of pocket. And we know that kind of treatment is not really sustainable, particularly with the average Nigerian living on 30,000, maybe that's like less than $500, really, or less actually, a month. We have noted lots of patients and provider delays along the patient's cancer journey. We have seen delays in access to treatments, and resulting in, is seen in about 80 to 90% of cases. So it's not just from the patient side, but then it's also because of the weak health system that we see in the government setting and in the private health setting. So these two components seem to worsen the late presentation that we see. So to add to all of that, it's clear that most of the times we do have high mortality rates and high morbidity rates again. And this does not encourage people to come to seek care early, because we are only just now trying to build successful cancer treatment stories, which we feel will motivate people to come to seek care early. And of course, if there is also financial protection as well. This is essentially what I talked about, but I just brought this up to show you, in as much as we've seen the population, the number of new cases, but really to draw your attention to the heavy burden that exists and the government would need to think about caring for in terms of cancer control, which is over 200,000. So there are a number of gaps that we see along the entire cancer care continuum, ranging from prevention and screening, diagnosis, treatment, retention, and supportive care. These are some of the things that we grapple with: limited coverage of proven approaches for prevention and effective screening. And again, because like I mentioned, we see more patients in the advanced metastatic case who the treatment offered is palliative, and ultimately we do not have good overall survival indices. So most of the population don't have a lot of faith really in the treatment that is being offered. But with the efforts now to try to cultivate the survivors and nurture them, we hope that this will help really in the health-seeking behavior of patients when they see something or feel something that is perhaps cancer. Like I mentioned, infrastructural capacity is limited. So there's poor diagnostic tools for bio and pathology imaging. This comes, and for centers that have developed it, particularly the private centers, it comes with an increased cost. And then for those centers, particularly in the government hospitals, that the costs are reduced because they are, they are just limited. It obviously will translate to long turnaround times. And occasionally, the quality also, it might be questioned because of QA services that are not as rampant and as frequent as they should be. Treatment is limited. There's limited availability of treatment. I will show you in the next slide, particularly with radiotherapy services, where we are in the country. We have very limited skilled surgical oncologists in the country. There are steps now with the new signing into law of the Nigerian Institute for Cancer Research and Training, which was just signed into law and operationalized this year. So there are talks about how to quickly increase skills for surgical oncologists to be able to at least perform surgeries on patients that need them. But with most of our patients still coming in locally advanced and metastatic states, we know that radiotherapy is important in this stage, and so also is systemic treatment. And we have problems also with this as well. Same thing also with retention and supportive care. I just want to draw your line to some of the cross-cutting gaps which have been noted here, which include the multi-step referral pathways, because we believe that if the primary health care is very strongly developed, patients that have to make it to the tertiary centers to access care will ultimately be referred back to their primary physicians to continue their care, have access to family support and supportive care, and it might also encourage people within the community to access care faster. As I have mentioned, there are financial constraints with procurement, provision, and it's a map showing the radiotherapy facilities that we have nationwide. There are currently only 14 linear accelerators present in the country, and we know that the IAEA recommendation is 1 linear to 200,000 patients. So by calculation, Nigeria should have somewhat around 2,000 linear accelerators, but we just have 14. The legends in yellow show the high dose rate brachytherapy, which is really important for completion of cervical cancer treatment. And we can see how sparsely located they are. The same thing also with the linear accelerators, which are in green. And we can see that there's a lot of geographic disparity. So this is something that the government also needs to take into consideration when trying to provide care for patients. We have to take into, with the large landmass, it takes almost like 2 days by land travel to go from Lagos, which is located in the southwest, to Borno, which is located in the far northeastern part of the country. The personnel also required to deliver safe and effective radiotherapy is also limited, with less than 100 radiation clinical oncologists practicing in Nigeria, and equally poor figures, limited figures for the medical physicists and the therapy radiographers as well. So this slide, very nice slide that I think I got from a colleague, highlighting the areas of intervention following the cancer continuum. But at the bedrock of all of it is the need for financial protection, because for people who are still struggling to feed, to clothe, to house, sometimes investing in health, bringing out funds to seek care for their health is somewhat of a challenge, whether it is in the preventive stage or screening, or even when they do need it for diagnosis, treatment, and support. So this is something that our government is trying to look into, because before the last 5 years, we did not really have any policy recommendations for financial protection with patients with cancer. So, like I said, that was in the past, but things are happening. We are beginning to see weakening government interest in Nigeria's healthcare financing for cancer patients. We know that the global consensus on financing universal health coverage indicates that the most sustainable and equitable funding source for healthcare provision relies on public financing as opposed to private. Out-of-pocket payments is regressive and responsible for catastrophic health expenditure and foregone care. And this is a typical picture we see here for patients one or two patients that come in early, that the healthcare team is excited that, we may be able to offer curative treatment. At some point along the cancer journey, they do drop out because of catastrophic health expenditure. Many of us will probably be familiar with the Abuja Declaration. Nigeria has sadly not been able to reach the commitment of 15% to the Abuja Declaration, and as typically the health expenditure has really been maybe somewhere between 4% and I think the highest is about 8% of GDP. And so the burden of financing healthcare in Nigeria is typically borne by the households and the community, because we tend to live a communal kind of living. So in the recent years, like I mentioned, there have been some changes in the policy landscape towards promoting universal health coverage for cancer in Nigeria. And I just thought to share a bit of some of the strategies that the federal government has recently put forward to help. One is the public-private partnership with the Clinton Health Access Initiative for Cancer Medicine. The goal of this venture is to provide access to essential cancer drugs, initially manufactured by Pfizer and Cipla, but now we have more companies that have come in, and we're able to get the drugs at now, I think it's reduced to almost 50% of what it used to be. So this has helped to drive uptake of systemic treatments, which again, I would like to stress is important for us here because our patients typically present in stages that require systemic treatments as part of their treatment or the only option of treatment that they have. Another initiative is the Cancer Health Fund, which we are particularly very excited about. It's a policy pronouncement by the Minister of Health, at the National Dialogue Conference in Abuja. And it's aimed at having a pool of funds from the federal government to directly support the treatment of cancer patients. It was established in 2019. The federal government budgeted and released the sum of 1.7 million to support cancer treatment for indigent patients. We prioritized the cancers that would, the patients that would be able to receive these funds, because our top 3 cancers nationwide are breast cancer, cervical cancer, and prostate cancer. So these funds have been earmarked to help indigent patients or patients with breast, cervical, and prostate cancer at the 6 tertiary health institutions across the country. And it was spread out so that we have 1 in each geopolitical zone. So while that was the initial pilot phase, and testing out implementation, we need to bear in mind the huge landmass of Nigeria, and where for people within that geopolitical zone to drive or to go to try and get access to that tertiary health institution, it can be quite a challenge, you know. So it could take as much as 3, 4, 5 hours, depending on the geopolitical zone you're in, to travel to go and access that service at that tertiary health center. Others include the Nigeria Finance Bill, which was set up in 2021. The aim was to aggregate funds again to support cancer patients, cancer treatment. And this was done by getting 1% tax from alcoholic beverages and sweetened drinks, sugary drinks as well, brewery industry, petroleum, mobile phone providers, cement, paint, and chemical manufacturing companies, because we do need a huge pool to be able to support and sustain government intervention for cancer care through the Cancer Health Fund. The NHIA Act, that's the National Health Insurance Act, was established in 2022, and makes it mandatory for health insurance coverage for all Nigerians. And before now, for those that had NHIA, or that was just basically with civil servants and those in formalized employment, it did not cover cancer care. But with this new act, we've seen that partners with support from pharmaceutical companies are able to defray up to 80% of the cost of cancer treatment for patients. And this is really important, particularly for HER2 breast cancer that require targeted therapy. And we know that the cost is prohibitive for most people. So oncology care has transitioned and has evolved and is now really basically personalized care. And the advent of personalized care came from the development and introduction of new cancer medicines. We know that the introduction of novel cancer medicines comes with a high price. And this is due to the extensive research and development that have been required to bring them into the market. So how will governments be able to prioritize which patients get what, how many they will get, and the effect this would have on the patient population? I think this is really what we hope to discuss today, and see if, if there are models that we can, follow to try to bring these cancer medicines at a cost that is beneficial to the government and also to the patients as well. So there are many considerations governments will encounter when evaluating these life-saving treatments. And this often includes assessing their economic viability, ensuring equitable access, and the need to follow guidelines and have this as informed consent, as informed decisions. We know that most of these personalized treatments that we see now, targeted therapy, immune checkpoint inhibitors, hormonal treatments, their clinical outcomes sometimes are not just overall survival indices that are being touted. Some is progression-free survival, disease-free survival. How do we really equate that and measure the cost-benefit analysis to governments that are trying to provide these services for their citizens. So I think I went back. So I just like to use our Cancer Health Fund as a case study to show how Nigerian government is trying to support cancer patients with the limited resources that we have, but trying to sort of like reduce the catastrophic health spending that most patients have had to undergo while seeking treatment for cancer. So the first thing we did when we're trying to put up the Cancer Health Fund was to do a needs analysis. Like I said, the priority was for cancers of the breast, cervix, and prostate, because these are the ones that we're really grappling with in our country. And the objective really was to, first of all, the medicine's cost effectiveness and evaluate its impact on patient outcomes. So once we did that, we entered into partnership with the Cancer Access Partnership, trying to pull in the drugs that are required to treat patients with these 3 diseases. And by doing that, we also took into consideration the costing, what the costing profile will look like, both direct cost of the drugs, cost of administration, cost of hospital stay, management of the side effects, and also the indirect costs, because like I mentioned before, we have lots of geographic disparities where patients can go and access care. So within the funds that are available to patients, we have funds that are earmarked for transportation, because we know that that can be a limiting factor to patients who might want to access care at the 6 tertiary hospitals. Then the next thing we considered was the clinical, how to assess the clinical outcomes. 2 years ago, Nigeria adopted as a standard protocol the NCCN harmonized guideline. Now, the reason for the NCCN harmonized guideline is because these are guidelines that have been taken into consideration our skill sets and the availability of the diagnostic tools we have and the drugs that we have. And the guidelines are prioritized based on that. It's color-coded, blue, gray, and black, and showing those that the services that should serve as the minimum standards, blue for regional differences if you have more, and then the gray, the high-end drugs and services that may not necessarily be available to all, but it's good to know that these are there. So we adopted the NCCN harmonized guidelines, and we had said that for patients accessing treatment on the Cancer Health Fund, that they must follow strictly the NCCN harmonized guidelines, so that we are trying to ensure the cost-benefit analysis while we do so. The Choosing Wisely movement, which ecancer is also part of, was also something we took into consideration, trying to devalue, de-implement low-value practices, again, trying to stretch the Naira as much as it can so that we are able to get more from it, as opposed to just doing the normal practices that were not yielding much value. Promoting equity and access is something we're struggling with, again, because I said colorectal cancer is also on the rise, non-Hodgkin's lymphoma is as well. So it's also something that we are looking at to see whether we can expand the portfolio of cancer that we can treat on the Cancer Health Fund. Now, this program started barely 2 years ago, so cost-benefit analysis is still work in process. What tools will we use? The frameworks will add. Like I mentioned, the Nigerian Institute of Cancer Research and Training was just recently signed into law and became operational. So this is something that we're hoping that they will really take under their belts to be able to provide M&E frameworks that will assess how much of an impact and at what cost this Cancer Health Fund intervention is making on outcomes, both patients, clinical outcomes, and also quality of life issues for cancer patients. So as I conclude, like to say that the cost benefit analysis of new cancer medicines presents governments with difficult choices, what to prioritize and what not, and balancing the potential clinical benefits of these therapies with their higher cost while ensuring equitable access for all citizens is a complex task. Nonetheless, these choices are crucial in managing healthcare expenditures and improving the overall health of populations. And there's really, really an important need to strike the right balance, and it would require collaboration between governments, healthcare providers, pharmaceutical companies, and patient advocacy groups to ensure that innovative cancer treatments are accessible to those who need them the most while maintaining the sustainability of healthcare systems. So with that, I'll turn it over to PJ, and thank you for your attention.
That was a brilliantly covered topic, which is not easy. And I think it definitely leads more questions to be asked and more work to be done globally I think you very eloquently covered the topic of personalized care being promoted versus how to balance that against equity and access due to financial constraints. And that kind of something you already said in your talk, but I just wanted sort of a little bit more discussion on the topic about what is cost benefit analysis? How do we put a number to it? And who has the right to do it? Should the individual governments be putting a number to it? I know we know NICE, which is the British sort of watchdog, has put a number of £20,000 to a per what we call as quality adjusted life years gained by each treatment. I mean, is it fair to put that number differently across different populations across the world when people are not finding it difficult to live their normal lives? Is it justified? I think, and how do we navigate that? I'm going to open that discussion to both you and Didier, and maybe even the other people in the panel, if they want to put their comments in the chat box, that would be very welcome.
Okay, so I think to your question, is it fair? No, it's not fair. Is it the realistic thing to do? Perhaps yes, because every country, every nation is at different places. There's different allocations of funding, at different stages. So we cannot run away from the fact that these differences will exist. But should they exist, I think is the million-dollar question, which if it's based on ethics and justification, it shouldn't. I know that lots has been said about the outcome of cancer not being dependent on the side of the globe that you live on, but sadly, this is the case. So who should be determining these numbers? Like I said in my last slide, it's a collaborative effort, I would say. The government obviously cannot do it alone because otherwise they would want to be as restrictive as possible. The clinicians should also not be left to do it alone because they probably don't understand how the funds are going to be made available. And we may come at it with a more compassionate side because we do see the patients. Same thing also with the advocacy groups. So I think it's a collaborative effort requiring all the key stakeholders in the room, having that honest dialogue, really trying to figure out what should work the best way and how to strike that balance. I know that in MDTs and when we try to see patients that we put on the CHF, we are trying to prioritize the stage 1 and stage 2 so that, in quotes, the government can see returns on their investments. Is that a fair approach? No. But so we do need to strike that balance. Some of the cancers that we see now today, again, with personalized treatments and really targeted treatment options that are available, have seen long and improved survival indices for patients with advanced cancers on targeted therapy, on immune checkpoint inhibitors and hormonal, so we should put all of that into considerations when we make the plan and, offer counsel to the government or the stakeholders as to who should get, when should get. And for us in Africa, we are also still struggling to put patients on best supportive care, knowing that at some point we have to say we should balance the quality of life as opposed to whatever treatments the patient, further treatments that the patient will be getting. So I think I'll just stop here and then maybe have Didier and others chime in.
Thank you. That was beautifully worded. Thank you. Didier.
Yes, I found it really a very interesting talk. Thank you for all your insights. I think we can debate a lot about it. I'm always a little bit afraid when I heard about pharma, because they, of course, they do a good job, but there is all the suspicion of money. And I think the Choosing Wisely initiative is very good. And I also think that you can do good, not the best, but with less money you can do good when you have a good organization of your care. And I think it's key in your country and in a lot of low middle income countries that all is put on more early diagnosis, on good organized care. I will ask you, what is the role of your nurses? Can they a little bit sometimes replace doctors? And how do you talk about choosing pharmas? But I would see, I think the most advantage is make, for example, by putting the ovaries away, ovarectomy in receptor positive breast cancer, giving tamoxifen. If in the case you give trastuzumab, give it 4 or 5 times, so you can really in a nice way, which you could say, yes, we must also give immunotherapy in a triple negative breast cancer, but I would think this is stupid. But I think really, if the government perhaps would discuss of or have something of a cancer plan and put these things for everybody, it will be perhaps helpful.
Thank you.
So I agree with you. I think most of that is tackled in the Choosing Wisely movement. Trying to show the drugs that would have the most benefits, most tangible benefit, as opposed to the ones that, are just moderate or just very small differences in the disease-free survival and all of those things. So no, and then as for the targeted therapies, we have conducted a study in 3 different institutions across the nation, because like many people, there was the debate as to, one, the role of targeted therapy in managing the HER2 positive patients, and because most of the studies really were done in populations that were not similar to ours, so considering the cost implications, really, is there really a role? So we looked at it, and of course it's clear to everybody that there is a role in this patient population. As to how much and when they should stop is also something that I think requires further interrogation. I know that there are studies that show that the giving it for 6 months is non-inferior, but then do our patients qualify? Because these are in early stage diseases, and most of our patients are locally advanced. So these are some of the questions that we are asking to see how we can really cut back and still at least maintain some level, in the quality of life of these patients. We do use a lot of tamoxifen, and we see that a number of our patients are in the premenopausal category. So for those that are early, and you really want to give both the tamoxifen and, the goserelin, inhibitors, that's an added cost. So we always have to strive and see the outcomes as opposed to how much it's going to cost, and try to just manage it and strike that balance. And for the records, we don't have immunotherapy in Nigeria.
But a small question, for example, goserelin, why not just take the ovary away? It's much cheaper.
It's much cheaper, but again, I started the slide talking about us being culturally diverse, we're working a lot with culture, a lot with our belief systems. So we also have to work with that as well, because the hints that at the end of this, we're going to lose all, hopes of childbearing is one most women will run away from and will not access your treatment. So in order to help them make that decision to come on to treatment, also have to protect their ovaries. So childbearing is priority for many of these young women. So it's not an option they will jump at, to take the ovaries away and look at alternative methods. It's beginning to, we're beginning to talk about it a bit more, but the average woman is not something she would, it's not an option she would, just logically, normally just jump on.
Thank you, Didier and Nwamaka. I think that's kind of boils down to the fact that all these guidelines requires people sitting within the healthcare, within the political system, within the financial streams of pharmaceutical industry to actually join their hands together to come on guidelines which are acceptable. Because at the end of the day, we want the patients to accept the treatments, which are, and of course, it's never going to be easy. I think Helena has put a comment in the chat that in terms of trastuzumab, which is Herceptin, even 3 months of treatment gives the majority of the benefit. So guidelines in resource-limited countries should surely be different. I think that's a very valid point, Helena, but I'll argue that it's slightly differently. There is a study which has now shown that the 6 months is not inferior to a year. So even the resource ample countries should not be over-treating patients unnecessarily, because no drug is without side effects. So why are we still continuing with 12 months of treatment when we know 6 months is good enough, particularly for early diseases? Why are we carrying on with extended treatments? That's my question to everybody out there. So why are we not adopting and changing the guidelines? So, and the next point I have, again, kind of similarly on the pharmaceutical side, where do we as medical fraternities sit, or how should we be doing things to limit the pharmaceutical industry's duration of patent on new drugs? We know a lot of work goes in, a lot of research goes in to bring these drugs up. So of course, there is a financial aspect of it, but at the end of the day, we're looking at cancer care, we're looking at productivity, we're looking at survivals. So how do should there be a concerted effort to limit that duration of patent and medicines? And this example, particularly given the pandemic, we know how different forces across the world came together to make more generic vaccines and for enhanced distribution to all the people in the world through WHO efforts. Shouldn't that be now applied to cancer world? I'll open that to discussion. Nwamaka, you are the first person.
So I like I said, I think I completely agree with you with the COVID vaccine, and we saw how very quickly the COVID vaccine, came into the market, and we had different countries producing it. I think we really need to look at that to see whether we can drop the prices very quickly. But the only, solution like we have now is, like I mentioned, with the Cancer Access Partnership, So these companies are producing drugs for LMIC, and it's supposed to be at the same standard. And then we are able to pool prescriptions together, pull the order and buy in bulk to reduce the cost of these drugs, and hopefully have them, shipped to us at a reduced cost. We have actually seen that once we joined the Cancer Access Partnership, we've seen a price reduction up to as much as 50%. Would we like more? Yes, certainly. So I think I'll just leave it here and perhaps see if others, have a way of their thoughts on, trying to bring down the prices very quickly.
Thank you. That's really helpful. Thank you. Didier, do you want to come in?
Yeah, two questions. Perhaps give me an answer about the role of nurses in your healthcare system and what can they do? And then just a quick questions. They mostly spoke about advanced breast cancer and how do you make the diagnosis? Is it mostly a clinical diagnosis or do you make a CT scan or is it not available? So that's two questions.
Okay, so in terms of the nurses, sorry, I actually omitted that. Yeah, so there's a lot of task shifting, that is going on right now, and the nurses are becoming more and more involved with cancer care. We have them also really actively involved in chemotherapy administration as well, and we're also trying to build a crop of oncology pharmacists to also support in that regard. The doctor-patient ratio in Nigeria is alarming. So obviously we are looking towards task shifting as much as we can. And, like I mentioned earlier on, most of the patients live in the rural settings where we have the community health officers and so we're trying to build capacity for screening, because now we know that CBE is now an established form of screening. So I'll try to take them on CBE and talk to them about cervical screening as well. My institution is currently involved in an NIH-funded grant to look at how to accelerate cervical cancer screen and treat at the community levels across the country. So again, building capacity for the low-level mid healthcare workers to try to fill that gap, because like you rightly pointed out, early detection, early diagnosis is critical, really, if we must change the narrative that we currently have in Nigeria. Then, sorry, the second question?
Yeah, it was just to know, how do you say it is advanced? You do it clinically, it's mostly clinically, or you do a CT, or is it just too big?
So I think breast cancer care has advanced beyond the clinical. Yes, so we do have the clinical, we have histological diagnosis and immunohistochemistry. This is standard minimum set of results or tests that we do for patients that have breast cancer. So for the equivocal on IHC, we have a problem with fish, but I think that with the new guidelines talking about HER2 low and all of that, but it's not like we also have the drugs available for the HER2 low. So it's still an issue, especially as we are still struggling with providing that service for the HER2 over-amplified as a HER2 positive 3+. So, but imaging, we have most of the tertiary hospitals across the countries have CTs. So we are staging with CT. We have one PET facility available in the country right now, but again, is mostly the private out-of-pocket expenditure because it's not covered by the Cancer Health Fund. What is covered is the histological diagnosis up to immunohistochemistry. So you are able to get your H&E and your IHC on the Cancer Health Fund. You are able to get your radiographs and you're able to get your CTs also on the CHF. But for prostate cancer, that would require MRI of the pelvis for proper delineation. They have to do that out of pocket.
Thank you.
Thank you, Nwamaka. I just want to read a couple of questions and comments on the chat. There's Amrinder Dhillon from, this looks like from Mumbai in India. He's mentioned that the dose optimization studies specific to low middle income countries can be a good strategy. And majority of the approval studies are done in the US and EU with dose and dosage as per Western body surface area in patients. For instance, recent study by Tata Memorial Hospital in Mumbai proved that low dose of Nivo was equally effective than high dose. I think I completely agree and endorse that. And I think what I would say is individual health sectors no matter where they are, need to come up with their customized studies and care plans to suit their population. And I think that's where the responsibility seems to lie. And I think the more we do that in our own population setting, we are making decisions which are more appropriate. So I think I completely endorse that. And the second is, what's your opinion for NDDS like fixed drug combinations, capecitabine and cyclophosphamide to bring down costs? I'm going to put that you to oncologists because I'm a poor surgeon who has no knowledge of drugs.
So for us, we typically would use the AC regimen as per guidelines, you know, of course, barring a good 2D echo result and all that. And it's affordable, it's cheap, and it's available. So capecitabine, on the other hand, is expensive. So we would obviously first line favor AC over capecitabine and cyclophosphamide. So the only other thing now is, you know, even with that, the ACs the anthracyclines are cheaper in comparison to the capecitabines, whether it's even the epirubicin or atramycin regimen.
And the taxanes are even more expensive, the taxanes?
Yeah, the taxanes are more expensive, but again, they are cheaper than capecitabine.
Yeah,
okay. Right. So I think whatever works in the local circumstances in terms of cost and effects, I think just to balance out the two and make a plan that works the best in the individual circumstances. But definitely the cost, what we have definitely agreed that the cost benefit is not a single figure or standard that can be applicable to people across the world for right or wrong reasons. And we need to make decisions which are pragmatic, practical, and applicable. So on that note, if everybody is happy, I will draw this webinar to a close. Nwamaka, thank you for doing a brilliant job. And it was very thought-provoking and certainly something that we all need to kind of work towards to making it a more just world if we can. But until then, we can be more pragmatic. And thanks, Jake. These are the upcoming grand rounds in breast cancer. The next one is on the 1st of December by Claudia Alemani and Nirmala Bhupati on global trends and inequalities in breast cancer survival and care. So many thank you for everybody joining from across the world, and we look forward to seeing you again in our next webinars. Many thanks. Thank you, Jake. Thank you, Didier, for your help and presence today. And thank you everyone for joining in, and have a good day. Thank you. Bye-bye.